The first step in open gloving is to take the sterile inner pack out of the non-sterile outer pack and then use the outer tabs of the inner sterile pack to open it up, creating a sterile field for your sterile gloves. Normally you would use your dominant hand first to get that glove on to make putting the other one on a little easier. I did not do that here. This is not my dominant hand, but I am trying to be a little more ambidextrous. So basically what I just did there was I used the cuff that was folded over to put that on, and now I'm slipping my fingers underneath to keep my non-sterile hand and my sterile hand separated so that I don't contaminate the glove that I already have on. And then you just slip them on and adjust them once they're on. Closed gloving is a little more involved. You have to make sure you have your mask and your cap on and sterile booties. We don't use them at our practice, so I just have my mask and my cap on. And here I'm opening my pack with my gown and my hand towel. If there's no towel in the gown pack, you have to open that separately, and usually we'll just open it onto the sterile field of that gown pack. I'm also opening my gloves here and getting them set up. Sometimes the assistant will do this for the doctor or for the assistant scrubbing in for surgery. And you open them kind of the same way, just trying to keep that sterile field from closing in on itself once you've had it open. At this point I have everything ready for once I have completed the scrub, and I'll be ready to gown up and glove in without any issue or needing assistance until I need to be tied in. So we have the prepared sponges at our practice, and what I'm doing here is I'm just wetting my hands down. I've already washed them. You don't have to wash them before scrubbing, but I like to just to kind of get any physical dirt off so that the scrub is really effective. And I use the block method. Right now I'm just cleaning the dirt out from under my fingernails. I had a tangerine that day, so there was a little extra gunk, and I just wanted to clean it off. And then once I've finished with that, I start scrubbing from my fingertips to my elbows. I like to scrub all my fingertips on one hand and then the other, and then do all my fingers on one hand and then the other, and then palms and backs of hands on one hand and the other, so on and so forth, up the arms. And you do that to make sure that the cleanest and most not sterile but clean part of your hand is your fingertips and the parts of your hand that are in the most contact with the patient, so that you can maintain as clean a procedure as possible. The block method involves scrubbing each part of the hand and arm as if it were a block, so 4 sides of the fingers and then the fingertips as well, and then the front, back, and sides of the hand, making sure to get in between the fingers, especially in between the thumb and the forefinger, areas that could harbor some bacteria. And as I'm scrubbing, I'm just counting somewhere between 10 to 40 brush strokes per side of the finger or side of the hand. Each little block is 10 to 40 strokes. Another method you could use is the time scrub. We don't have a clock readily available, and I personally find the block method easiest to make sure I get every part of my hands and arms clean and scrubbed really well. Now I'm about done scrubbing, so I'm getting ready to rinse, and you rinse the same way that you scrub, from fingertips to elbows, making sure you don't allow any water to drip back down towards your fingertips, because it could be dirtier or contaminated if it drips down to a part of your arm that you didn't scrub. This is an interesting challenge, especially for me. I have kind of long arms where when I rinse my hands, I have a cabinet in my way and a little bit too much arm, but I did manage to avoid it. Just takes a little extra rinsing and technique. Now I've finished scrubbing, and my hands are rinsed, my arms are rinsed, there's no soap left, so I'm just kind of air drying a little bit, and then I'm going to carefully grab my towel and dry one hand at a time using one side of the towel for my first hand, and making sure I really get my hands nice and dry in between my fingers, and then down my arms. Drying is the same as scrubbing and rinsing. You work from your fingertips all the way down, just trying to maintain as clean hands as possible, because about 50% of gloves are punctured by the end of a procedure, so we just want to make sure we have as little bacteria on our hands as possible. And once I finish with this arm, I switch to the other side of the towel to make sure it's dry and will properly dry my other hand as well. Maintaining that cleanliness. I just drop my towel as I've dropped everything else. I don't want to touch anything now that my hands are clean. I picked up my sterile gown, and I'm careful not to let it touch anything, and I try to just touch the inside with my scrub so that the outside doesn't become contaminated. Once I've got my sleeves on, I make sure that my hands don't exit the cuffs of the sleeves. My arms are kind of long, so sometimes it is difficult and I have to have a little bit different technique. And my assistant Brennan is tying me in here, and then I will start the gloving process. I'm still learning which method I prefer. Here, Brennan turned my gloves around for me so I could use Dr. Aller's method. I think that I prefer using my own method of just keeping them straight, because I had a little trouble reorienting myself with the handshake method that she uses, but we figured it out. So again, I made the mistake of not using my dominant hand first, but that's all right. We got it worked out, and I'll get in a better habit of doing my right hand first. But here I am putting my left glove on. I'm grabbing the one side of the folded over cuff with my left hand, which it is going on, and the other side with my right. And slowly working my hand through the cuff and then into the correct finger holes. It's a little bit difficult for me with these gloves because they're not quite the right size. They're a little bit small on me. I need a 7.5, and the biggest size that we have is a 7. So I do struggle a little bit, but I get them on eventually. Once that one is on, it's sort of the same idea as for open gloving. I just slip my fingers under the cuff of the other glove, place it on my hand so that I can flip the cuff over the cuff of the gown, and then slowly work my fingers through the cuff of the gown and into the correct holes of the glove, and all being very careful not to contaminate the sterile fields of my gloves and my gown. Hopefully in the future there will be a little more opportunity to practice this and actually be able to scrub in for procedures. As you can tell, did struggle a little bit with these gloves. They're being too small and just not really ever having the opportunity to do this in practice. But hopefully that will change, and we'll have a little more ability to help out in surgeries in an aseptic fashion. Drawing blood from the cephalic vein starts out by wetting the area with a little bit of alcohol to help dilate the vein and make it pop up a little bit. And also to clean the area, not sterilize it, but clean it just a little bit. Then palpating the vein and stabilizing by placing my thumb on one side of it. And then I insert the needle, bevel up at a slight angle, wait for the flash of blood, and then aspirate back. Sometimes you have to reposition because the needle moves just slightly out of the vein, and the best way to do that is to back straight out, then readjust your angle, and then go back in. You don't want to lacerate the vein by moving the needle around too much inside the space. When I'm finished with my draw, I will let the assistant know so that she can let go of her pressure and hold off on the vein where I've removed my needle. Intramuscular injections start out the same. You cleanse the area with some alcohol first, and then for our practice we always inject pre-meds into the epaxials, and you find those by feeling for the ilia and then moving cranial just a little bit and just lateral to the spine, palpating that epaxial muscle, and do the injection there. You just vary the depth of your needle and the size of your needle based on your patient and the amount of fat or lack of fat that they have. I will say I failed to aspirate back once I did place the needle, and I did notice that there was no flash of blood in the hub. I just did not aspirate back. The first step in IV catheterization is to gather your materials, which include electric clipper, 40 blade is what we use, and your catheter, choosing the correct size for your patient. We typically use a 22 gauge unless it's a larger dog, and you also need your heparin flush, an injection cap, or a T-set depending on what you're placing the catheter for. You also need your tape. Everybody has a different method of taping. I'm still learning my preferences, so I try a couple of different things every time I try to place a catheter. Once you've got everything, you can shave, going with the grain first and then against the grain, being careful not to cause any irritation like razor burn or clipper burn. And then I like to get all of the hair out of the way. If there's any hair, long hair underneath on the other side of the leg, then I like to either trim that down or have the assistant kind of hold it in their hand to keep it out of the way when I start taping. You also need your scrubs, so you get your, we have bins of sterile scrub prepared and alcohol, soap gauze. So I like to scrub and then wipe with alcohol 3 times. And then I will get my catheter ready. We like to flush our catheters first with heparin flush before placing them, just to be sure there's nothing wrong with the catheter. Every once in a while you'll come across something that is a manufacturer's defect, and we like to be sure that what we're trying to place doesn't have a defect and cause any sort of irritation. So I just make sure I can see the vein and place the catheter going in at a 15-degree angle until I see a flash of blood. And once I see that flash, I flatten out and advance about 1 to 4 millimeters more. And then I slide the catheter into the vein and slide the stylet out, make sure there's blood still flowing. And then I place the cap on the end and then tape in. I think what I'll probably do is use larger pieces of tape because, as you will see, I fumble with the tiny pieces that some of our technicians like to use, and they get stuck together and twisted, and I just seem to prefer the thicker pieces of tape, but worked with what I had and it went well. Once I'm satisfied with my tape job, I flush the catheter to make sure that the blood doesn't clot in the catheter and there's a free flow. It also is nice to do this so that you can make sure that you're actually still in the vein and the catheter hasn't come dislodged somehow in the process. There are a lot of steps in getting the OR ready for surgery. We clean at least an hour before to make sure that everything has settled by the time surgery is ready to start. And then we'll go ahead and prepare as much as we can for the patient. This is the bear hugger that I'm setting up here. We like to use this in the surgery suite and the water heating pads that we have for dentals outside of the surgical suite in the prep room. Just because with the bear hugger it's dry and there's no chance of puncture and then leakage causing strike through of the drape in surgery. Once the patient is under anesthesia, we will flip them over and get them prepped for surgery, starting by shaving, going with the grain first, and then against the grain once the hair has been trimmed. Um, Always check with the doctor before you begin trimming, just to make sure you're clipping enough hair for them and you're clipping the right area. For our doctors, they typically like for us to go just slightly up the legs from the inguinal area and then to about half of the scrotum for a neuter. This is a dog neuter. He's a very young one, so it's hard to see all of his anatomy. I'm just being very careful not to give the dog any sort of irritation like clipper burn, because that can be a reason that dogs tend to lick that area after surgery if there's some sort of irritation. So anything I can do to cause the dog as little pain or discomfort, I'm going to take those precautions and take my time. I also want to make sure that the clip is fairly even and looks nice, so that the owners are not offended by their dog's poor haircut. Once I think I might be done with the shaving, I always double check with a more senior technician or the surgeon performing the surgery, just to make sure I've got everything clipped the way that they would like it. Make adjustments as needed, and then once everything is clipped, I'll vacuum all the extra fur away and then move into the surgery room. I will say as a disclaimer, I encountered a lot of issues with this particular procedure. You will notice as I'm tying in, the dog is flopping around a little bit, so normally we would go ahead and V the table. The table decided to break as we were trying to do the V, and so abandoned that in the middle and just made adjustments as needed and retied properly. Also encountered an issue that you will see with the fluid pump. There was air in the line, so it took me a little time to go ahead and bleed the air through the line and fix other issues that kept occurring. There was also an occlusion, and it just took a little bit of time to get that all set up and squared away for our friend Angus. Eventually, everything did get tied in and all the leads were attached. I abandoned the tying in of the dog when I realized it was going to take a little bit more time, and just decided that getting those ECG leads attached was the most important so that the technician could monitor appropriately. Typically, we have at least 2 people working on getting everything set up, and one person will keep a close eye on monitoring color and heart rate while the other person gets the ECG leads attached and the blood pressure cuff and the temperature probe all placed, and then together we will stand on either side of the table and make it a V if necessary, or adjust the way that we tie in the patient, and the patient will be tied in on both sides by each person, and then one person will scrub and the other person will monitor. Um, it moves a little more quickly, a little more smoothly when we have our normal 2 people, and we don't have all of these issues pop up, but deal with them as they come and do the best we can with them. Everything worked out well, just took a little bit longer than expected, so I do apologize for the length of this portion of the video. Once I have the patient tied in properly, he seems to straighten out and stay flat and in a good position for the doctor. So it turned out we didn't need the V after all, or anything on his sides, which was nice. So I'm able to adjust the lights properly for the surgeon and begin the scrub. So for the scrub, I start with a Chlorohex-soaked gauze with a gloved hand, and beginning from the center where the incision will be made and working my way in a circular motion outward, not going over the second area twice. I'll scrub the area did decide after the first one to go ahead and do kind of a dirty scrub because he was a little dirty. His prepuce was a little crusty, so we did do a little extra scrub with him. But once the sterile scrub starts, we do the circular motion of Chlorhex, followed by an alcohol wipe, and then repeat that 3 times, and then finish with the betadine. As I've said before, we don't get a lot of opportunity in our practice to help with surgery as a scrubbed in sterile assistant. So hopefully in the future we'll have a little bit more opportunity to do so. This is a canine neuter that we're performing here on our friend Angus, myself, and Dr. Barker. Every once in a while we will have a cruciate repair that will help with not scrubbed in, but as a circulating nurse. I would like to get some experience doing this to be a little bit more comfortable, but I think for the most part I have a general understanding and awareness, and I feel comfortable being in a sterile environment. Most of our procedures are neuters and spays. Every once in a while we'll see a mass removal. We do a lot of dentals. We don't really get to do a whole lot of really involved surgeries though, which I'm hoping to get a little more experience with either here or at another practice in the future. I think it's really interesting to see some of the procedures, some of the things that we're able to do with veterinary medicine. It's pretty amazing these days.